So now we will discuss about the local anesthetics. Okay, in the local anesthesia, drug act by causing reversible block to conduction along the nerve fiber. Okay, these drugs cause reversible block to conduct along the nerve fiber. Okay, the drugs penetrate the nerve in a non-ionized lipophilic form. Okay, the drug penetrates the nerve in a non-ionized lipophilic form, but once inside the axon, some ionized molecules are formed, and this block the voltage-gated sodium channels. Okay, so what happens? Then the drug penetrates the nerve in an non-ionized lipophilic form, but once the inside the axon, the some ionized molecules are formed. Okay, first it is in the non-ionized form, then the ionized molecule are formed, and this block the voltage gated sodium channels, preventing the sodium current and the generation of action potential. Okay, so it prevents the sodium current and generation of the action potential. They vary widely in their use, potency, toxicity, duration of action, stability, solubility in the water, and ability to penetrate mucous membrane. Okay, so first we will see the lidocaine. So lidocaine is the most widely used local anesthesia. It acts rapidly and when administered with adrenaline, the block lasts about 90 minutes. Okay, when in the it is used very rapidly and it is used in the local anesthetics. Okay, it acts rapidly and when administered with the adrenaline. Okay, it block lasts about 90 minutes. Lidocaine is effectively absorbed from the mucous membrane and can therefore be used as a surface anesthetic in a concentration up to 10%. Okay, except for surface anesthesia and dental anesthesia. Solution should not usually exceed 1% in strength. Okay, should not exceed 1% in strength. Lidocaine also has a class 1b antiarrhythmic property, block inactivated voltage gated sodium channel, and may be given intravenously in the treatment of ventricular arrhythmia. So, lidocaine is the most widely used local anesthetic. Okay, it acts rapidly, and when administered with the adrenaline, it block lasts about 90 minutes. Okay, lidocaine is effectively absorbed from the mucous membrane and can therefore be used as a surface anesthetic in concentration of about 10 percentage up to 10 percentage, except for surface anesthesia and dental anesthesia. Solution should not be exceed 1% in strength. Okay, surface anesthesia and for the dental anesthesia 1%, it should not be used greater than 1% of the strength. Okay, lidocaine also has the class 1b antiarrhythmic property. Okay, it block inactivated voltage gated sodium channel and may be given intravenously there in the treatment of the ventricular arrhythmia. Okay, now we will see the prelocaine. So prelocaine hydrochloride is a local anesthetic of low toxicity. Okay, prelocaine hydrochloride is a local anesthetic. Okay, of low toxicity, which is similar to the lidocaine, but is more extensively metabolized and in less toxic in the equipotent doses. Okay, it is prilocaine is a less toxic effect. It is most frequently used for the intravenous regional anesthesia. Okay, it is most frequently used for the intravenous regional anesthesia, like Bayer's block. Mears block anesthesia is an intravenous regional anesthesia technique in which an extremity, usually the arm, is anesthetized by the injection a local anesthetic solution, okay, typically prelocaine, into a vein after the limb has been exsanguinated and tourniquet placed on it. The tourniquet prevents a potentially toxic dose of local anesthesia from leaving the extremity and blood from entering it, giving the patient an anesthetized extremity and the surgeon bloodless field. Okay, understood that the prelocaine is a local anesthetic of low toxicity, which is similar to the lidocaine. Okay, but it has less toxicity. Okay, it is the most frequently used for the intravenous regional anesthesia, like in the Beer's block, when the intravenous regional anesthesia technique in which an extremity is anesthetized by injection a local anesthetic solution in the vein after the limb has been exsanguinated and a tourniquet placed on it. Okay, the tourniquet prevent a potential toxic dose of local anesthesia from leaving the extremity and the blood from entering in it. Okay, then the EMLA, EMLA. Amla cream, an effective topical local anesthetic, okay, is a 50 by 50 mixture of 2.5 percentage of the prilocaine and 2.5 percentage of the lidocaine. Okay, Amla cream is a topical local anesthetic, 50 by 50 mixture, 2.5 percentage of the prilocaine and the 2.5 percentage of the lidocaine. Okay, then the bupivacaine. So bupivacaine has a longer duration of action, okay, then the other local anesthetic, okay, up to 8 hour uh, when used for nerve block. It has a slow onset, taking up to 30 minutes of for full effect. Okay, bupivacaine has a longer duration of action than the other local anesthesia. Okay, bupivacaine has a longer duration of action. Okay, up to 8 hours when used for the nerve block. It has a slow onset and taking up to 30 minutes for full effect. Okay, it has a longer duration of action of around 8 hours, and it has a slow onset, and it take up to 30 minutes for full effect. It is often used in the lumbar epidural blockage, and is particularly suitable for the continuous epidural analgesia in labor or for the post-operative pain relief. Okay, it is often used in the lumbar epidural blockage. Okay, particularly suitable for the continuous epidural analgesia in the labor. Continuous epidural analgesia in the labor or for post-operative pain relief. In the post-operative pain relief, it is the principal drug used for the spinal anesthesia. Okay, uh, it is often used in the lumbar epidural blockage and is particularly suitable for the continuous epidural analgesia in the labor or for the post-operative pain relief. It is the principal drug used for the spinal anesthesia, the bupivacaine. Then we will discuss about the vasoconstrictor. Okay, local anesthetic cause dilatation of the blood vessel. The addition of the vasoconstrictor, such as adrenaline or epinephrine, to the local anesthetic uh, preparation diminish local blood flow, slowing the rate of absorption and thereby prolonging the anesthetic effect. Great care should be taken to avoid inadvertent intravenous administration of a preparation containing adrenaline or epinephrine, and it is not advisable to give adrenaline or epinephrine with a local anesthetic injection in digits or appendages because of the risk of the ischemic necrosis. Okay, understood. So vasoconstriction with the local anesthesia should is given nowadays because the local anesthesia causes the vasodilatation, causes dilatation of the blood vessels. In addition of the vasoconstriction such as adrenaline or epinephrine to the local anesthesia preparation diminishes the local blood flow. It causes decrease the local blood flow, slowing the rate of the absorption and thereby prolonging the anesthetic effect. Great care should be taken to avoid inadvertent intravenous administration of the preparation containing adrenaline or epinephrine, and it is not advisable to give adrenaline and epinephrine with a local anesthetic injection in the digit and appendages because of the risk of the ischemic necrosis. Okay. Adrenaline and epinephrine must be used in a low concentration when administered with local anesthesia. Care must also be taken to calculate a safe maximum dose of local anesthetic, okay, when using combination product. Okay, care must be taken to calculate the safe maximum dose of the local anesthesia using the combination product. Now, in patient with a severe hypertension or unstable cardiac rhythm, the use of adrenaline or epinephrine with a local anesthetic may be hazardous. Okay, with the severe hypertension or unstable cardiac rhythm patient, adrenaline or epinephrine combination local anesthesia may be hazardous. For this patient, anesthetic without adrenaline should be used. Okay, understood. Then the toxicity. So, toxic effect after administration of local anesthetic are a result of excessively high plasma concentration. Okay, toxic effect after administration of local anesthetic are a result of excessively high plasma concentration. Okay, severe toxicity usually result from the inadvertent intravascular injection or too rapid injection. Okay, intravascular injection or too rapid injection. Following most regional anesthetic procedure, maximum arterial plasma concentration of anesthetic develops within about 10 to 25 minutes. So, careful surveillance for toxic effects is necessary during the first 30 minutes after the injection. Local anesthetic depress other excitable tissue producing central nervous system effect with increasing toxic dose like sedation, lightheadedness, anxiety, and the restlessness. Then twitching, tremor, and visual disturbance, convulsions, coma with respiratory depression result from the medullary depression. Then the cardiovascular effect are vasodilatation, partially by direct action or on the blood vessels and partially by blocking their sympathetic nerve supply with hypotension. Myocardial depression with bradycardia. Okay, so toxicity. Toxic effect after administration of the local anesthesia are a result of excessive high plasma concentration. Okay, severe toxicity usually result from the adventant intravascular injection or too rapid injection. Maximum arterial plasma concentration of anesthetic develop within 10 to 25 minutes. Okay, so careful surveillance of for toxic effect is necessary during the first 30 minutes after injection. Local anesthetic depresses other excitable tissue producing it depresses the other excitable tissue producing central nervous system effect with increasing toxic doses like sedation, lightheadedness, anxiety, restlessness, then the twitching, tremor, visual disturbance, then the convulsion and coma, and with respiratory depression resulting from the medullary depression. Then the cardiovascular effect like vasodilation with the hypertension and myocardial depression with the bradycardia. Now, muscle relaxant. So, neuromuscular blocking drugs used in anesthesia are also known as the muscle relaxant. Okay, neuromuscular blocking drugs used in anesthesia are also known as the muscle relaxant. Okay, by specific blockage of the neuromuscular junction, they enable light anesthesia to be used with adequate relaxation of the muscle of the abdomen and the diaphragm. Okay, so by specific blockage of the neuromuscular junction, they enable light anesthesia to be used with the adequate relaxation of the muscle of the abdomen and the diaphragm. They also relax the vocal cord and allow the passage of the tracheal tube. Their action differ from the muscle relaxant used in the musculoskeletal disorder that act on the spinal cord or brain. Okay, so it causes the relaxation of the muscles in the abdomen and the diaphragm and also relaxes the vocal cord for the passage of the tracheal tube. Patients who have received a neuromuscular blocking drug should always have their respiration assisted or controlled until the drug has been inactivated or antagonized. They should receive sufficient concomitant inhalational or intravenous anesthetic or sedative drug to prevent the awareness. Okay, they should always receive sufficient concomitant inhalational or intravenous anesthetic or sedative drug to prevent the awareness. Non-depolarizing agent. Non-depolarizing agent. So, non-depolarizing muscle relaxant drug like atracurium compete with the acetylcholine. Okay, like atracurium. Non-dependent, non-depolarizing agent, non-depolarizing muscle relaxant like atracurium compete with the acetylcholine. Okay, molecule released from the presynaptic membrane at the neuromuscular junction by binding with the acetylcholine receptor on the postsynaptic membrane of the motor end plate, blocking the action of the acetylcholine and preventing the depolarization and muscle contraction. Okay, non-depolarizing muscle relaxant like atracurium compete with the acetylcholine molecule released from the presynaptic membrane at the neuromuscular junction by binding with the acetylcholine receptor to the on the postsynaptic membrane of the motor end plate, blocking the action of the acetylcholine and preventing the depolarization and the muscle contraction. Okay, none of these drug cross the blood-brain barrier, not crosses the blood-brain barrier. Okay, as they are water soluble polar molecules and therefore have no effect on the CNS system. Okay, it is they are the water soluble and no effect on the CNS. Okay, they have no sedative or analgesic effect and are not considered to trigger malignant hyperthermia. Okay, they have no sedative or analgesic effect and are not considered to trigger the malignant hyperthermia. Okay, now non-depolarizing neuromuscular blocking drugs have a slower onset of action. Okay, have a slower onset of action. Okay, then the succinylcholine chloride and can be classified by their duration of action as a short acting 15 to 30 minutes. intermediate acting 30 to 40 minutes, and the long acting 60 to 120 minutes. Although duration of action is dose dependent, non-depolarizing neuromuscular blocking drugs have a slower onset of action than the suxamethonium fluoride have a slower onset of action and can be classified by their duration of action. They are classified by the duration of action, like short acting 15 to 30 minutes, intermediate acting 30 to 40 minutes, and long acting 60 to 120 minutes. Although duration of action is dose dependent. Atracurium bacillate is a benzyl isoquinolinium neuromuscular blocking drug. Okay, atracurium with an intermediate duration of action. It has the intermediate duration of action. It undergoes non-enzymatic metabolism, which is independent of liver, kidney, and function. Okay, it is undergone non-enzymatic metabolism with independent of the liver, kidney function, thus allowing it used in the patient with hepatic or renal impairment. Cardiovascular effects such as flushing, tachycardia, hypotension, bronchospasm are associated with significant histamine release. Okay, histamine release can be minimized by administering slowly or in divided doses over at least 1 minute. Okay, so atracurium has an intermediate duration of action, and it undergoes non-enzymatic metabolism, which is independent of the liver and kidney function. So it can be given in the hepatic or renal impairmented patient. It has a cardiovascular effect such as flushing, tachycardia, hypertension, and the bronchospasm. Okay, due to the release of the histamine, and this cardiovascular effect or the histamine effect can be minimized by administering slowly or in the divided dose over at least 1 minute. Okay, all non-depolarizing drugs should be used with care. Okay, should be used with care in patients suspected to be suffering with myasthenia gravis. Okay, all non-depolarizing drugs should be used with care in patients suspected to be suffering from the myasthenia gravis or myasthenic syndrome, as patients with this condition are extremely sensitive to their effect. Okay, uh, should be used with care in patients suspected with suffering from the myasthenia gravis or myasthenic syndrome, as this patient this condition are extremely sensitive to their effect. Okay, uh, neostigmine, an anticholinesterase is used specifically for reversal of non-depolarizing competitive blockage. Okay, neostigmine is used specifically for the reversal of non-depolarizing competitive blockage. It acts within 1 minute of the intravenous injection. Okay, it's used specifically for the reversal of non-depolarizing uh, competitive blockage. Okay, so it's the antagonist of this non-depolarizing agent. It acts within 1 minute of the intravenous injection. Okay, it acts within 1 minute of IV injection, and its effect lasts for 20 to 30 minutes. A second dose may be then be necessary. Okay, so we have seen here the non-depolarizing agent. Okay, non-depolarizing muscle relaxant. Okay, drugs like atracurium compete with the acetylcholine, that we understood that. Okay, then none of the this drug cross the blood-brain barrier, so they have no any CNS effect. Okay, and no any sedative or analgesic effect. Okay, non-depolarizing neuromuscular blocking drug have a slower onset of action, and they are classified by their duration of action, like short, intermediate, and long acting drug. Okay, adragurium is an intermediate duration of action, has an intermediate duration of action and non-enzymatic metabolism, which is independent of the liver and kidney, so they can given in their impaired condition. Okay, and has a minimal cardiovascular effect like flushing, tachycardia, hypotension, and the bronchospasm, and due to the histamine release. So, and this effect can be minimized by giving it slowly. Okay, all non-depolarizing drugs should be used with care because suspected to be suffering from the myasthenia gravis or myasthenic syndrome. Okay, patient with this condition are extremely sensitive to their effect. Okay, and the neostigmine and anticholinesterase, okay, is used specifically for reversal of non-depolarizing competitive blockage. Okay, within 1 minute of intravenous injection. Okay, and their effect lasts for 20 to 30 minutes. So after this uh, second dose may be then needed. Okay, now depolarizing agent. So depolarizing muscle relaxant produce what appear to be a persistent depolarization at the neuromuscular junction by binding to the acetylcholine receptor. So depolarizing agent, depolarizing muscle relaxant produce what appears to be persistent depolarization at the neuromuscular junction by binding to the acetylcholine receptor and mimicking the effect of the acetylcholine but without dissociating from the receptor and being rapidly hydrolyzed by the acetylcholine esterase. Okay, propagation of an action potential is prevented by the area of inexcitability that occurs around the acetylcholine receptor. Succinylcholine is the only depolarizing muscle relaxant. Okay, with clinical usefulness, has the most rapid onset of action of any of the neuromuscular blocking drugs, and is ideal if fast onset and brief duration of action are required. Okay, so what we have seen here, that the depolarizing muscle relaxant produce what appear to be persistent depolarization at the neuromuscular junction by binding to the acetylcholine receptor and mimicking the effect of acetylcholine but without dissociating from the receptor, being rapidly hydrolyzed by acetylcholine esterase. Okay, propagation of an action potential is prevented by the area of excitability that occurs around the acetylcholine receptor. Okay, succinylcholine is the only depolarizing muscle relaxant with clinical usefulness. Now has the most rapid onset of action of neuromuscular blocking drug. In ideal is ideal if fast onset and brief duration of action are required. Okay, unlike the non-depolarizing neuromuscular blocking drug, its action cannot be reversed, and anticholinesterase such as neostigmine actually potentiate the neuromuscular block. Okay, recovery from the succinylcholine is spontaneous. The drug is normally hydrolyzed rapidly, 5 to 10 minutes by plasma pseudocholinesterase. Reduced cholinesterase synthesis in end stage hepatic disease or congenital deficiency may increase the duration of action resulting in the prolonged paralysis with apnea. Okay, unlike the non-depolarizing neuromuscular blocking drugs, its action this depolarizing agent's action cannot be reversed. Okay, and anticholinesterase such as neostigmine actually potentiate the neuromuscular block. It increase the neuromuscular block. Recovery from the succinylcholine is spontaneous. The drug normally hydrolyzed rapidly within 5 to 10 minutes, okay, by plasma pseudocholinesterase. Okay, reduced plasma cholinesterase synthesis in end-stage hepatic disease, reduced plasma cholinesterase synthesis in end-stage hepatic disease or congenital deficiency may increase the duration of action. Okay, suxamethonium should be given after anesthetic induction. Okay, suxamethonium should be given after anesthetic induction because paralysis is usually uh, preceded by the painful muscle fasciculation. Okay, because paralysis is usually preceded by the painful muscle fasciculation due to the initial end plate depolarization. Due to the initial end plate depolarization, as asynchronous muscle fiber twitches causes damage, which can result in muscle pain the next day. Okay, and also potassium release and hyperkalemia. Okay, while tachycardia occurs with single use, bradycardia may occur with repeated doses in adults, with the first dose in children and with the first dose in the children. Pre-medication with glycopyrronium bromide or alternatively atropine sulfate reduces the bradycardia. Excessive salivation and other muscarinic effects associated with suxamethonium use. Okay, so what we have learned here that the suxamethonium should be given after anesthetic induction. Okay, after anesthetic induction because paralysis is usually preceded by the painful muscle fasciculation due to the initial end plate depolarization okay, asynchronous muscle fiber twitches, okay, causes damage which can result in the muscle pain the next day. The and also potassium release and the hyperkalemia with tachycardia with the first single dose, and the bradycardia may occur with the repeated dose in adults and with the first dose in the children. Pre-medication with the glycopyrronium bromide or alternatively atropine sulfate reduces the bradycardia. Okay, premedication will reduces the bradycardia and excessive salivation and other muscarinic effect associated with the suxamethonium. Now, malignant hyperthermia. Okay, malignant hyperthermia is a rare but often fatal complication in susceptible patients that results from the rapid increase in the muscle metabolism. Okay, malignant hyperthermia is a rare but often fatal complication in the susceptible patients that result from the rapid increase in the muscle metabolism. About 50% of the patients are genetically predisposed. It is characterized by the tachycardia and among other manifestations, intense muscle spasm. Okay, intense muscle spasm that result in rapid and profound hyperthermia. Okay, malignant hyperthermia is a rare but often fatal complication in the susceptible patient. Okay, that result from the rapid increase in the muscle metabolism result in the result from the rapid increase in the uh, muscle metabolism. Okay, uh, in the 50% of patients are generally predisposed. Okay, it is characterized by the tachycardia among other manifestations, intense muscle spasm that result in the rapid and profound hyperthermia. Okay, so that was the depolarizing agent. Then naloxone. So, opioid toxicity can cause the coma, respiratory depression, and pinpoint pupil. Opioid toxicity can cause coma, respiratory depression, and the pinpoint pupils. Naloxone is a specific antagonist, okay, specific antagonist of the mu opioid receptor. Okay, okay. Opioid toxicity can cause the coma, respiratory depression, and the pinpoint pupil. And naloxone is the specific antagonist of the mu opioid receptor. Naloxone hydrochloride will immediately reverse opioid-induced respiratory depression. Okay, it immediately uh, reverse the opioid-induced respiratory depression. Okay, immediately reverse the opioid-induced respiratory depression, but will also antagonize the analgesic effect. Okay, it also antagonize the analgesic effect. It will also precipitate withdrawal syndrome when dependence has occurred. Okay, it also precipitate the withdrawal syndromes. Okay, naloxone should only be given by subcutaneous or intramuscular route. If intravenous route is not feasible, intravenous administer has more rapid onset of action. Okay, the BNF recommends naloxone 0.4 milligram to 2 milligram intravenously in adult, repeated every 2 to 3 minutes up to maximum of around 10 milligram. If respiratory depression uh, does not improve, then question the diagnosis. Okay, in practice, most overdose will respond to 400 microgram to 800 microgram of the naloxone. Okay, so what we have seen, that the naloxone, in the naloxone it is opioid antagonist. Opioid toxicity will cause the coma, respiratory depression, and the pinpoint pupil. Naloxone is the antagonist of the mu opioid receptor. Okay, naloxone hydrochloride will immediately reverse the opioid induced respiratory depression, but will also antagonize the analgesic effect. Okay, it is okay. The naloxone should only be given by sub-Q or intramuscular route if intravenous is not feasible. Intravenous administration has the more rapid onset of action. Okay, it is given 0.4 milligram to 2 milligram intravenous in adults. Okay, and in repeated, it can be repeated every 2 to 3 minutes up to maximum of the 10 milligram. If the respiratory depression is not reversed, then we have to question the diagnosis. Okay, in practice most overdose will respond to 400 microgram to 800 microgram of the naloxone. Okay, since naloxone has a shorter duration of action, uh, then many opioids 1 to 2 hours close monitoring and repeated injection may be necessary if the respiratory function deteriorates. Okay, since naloxone has a shorter duration of action than many opioids, uh, which have the 1 to 2 hours of the duration of action. So naloxone is given repeatedly, so the close monitoring should be necessary if the respiratory function deteriorates. When repeated administration of the naloxone is required, it can be given by a continuous intravenous infusion. Instead, the rate of the infusion adjusted accordingly. Okay, and the rate of the infusion adjusted accordingly. The effect of some opioid such as the buprino, buprenorphine and the tramadol are the only partially reversed naloxone. Okay, uh, buprenorphine and the tramadol are the only partially reversed by naloxone. Okay, only partially reversed by the naloxone. Methadone has a very long duration of action. Patients may need to be monitored for long period following the large overdose, up to around 72 hours. Okay, so what we have seen here, that the naloxone should only be given sub should be given in the intravenous dose, and if it's not feasible, then the sub-Q or IM dose can be given. Its dose is the 0.4 to 2 milligram IV, and it can be repeated at every 2 to 3 minutes. Okay. And okay, its response is mainly come in 400 to 800 microgram dose. Okay, since naloxone has a shorter duration of the action than many opioid, which have the 1 to 2 hours of the duration of action, close monitoring and the repeat injection should be necessary. Okay, and when repeated administration of the naloxone is required, it can be given by continuous IV infusion. Okay, the effect of some opioids such as buprenorphine and the tramadol are very partially reversed by the naloxone when the methadone has a very long duration of action. Okay, and for that the large overdose is given up to 72 hours. A large overdose will its effect have 72 hours, so the naloxone also we should be continue for till that. Then the nitrous oxide is used for the maintenance of the anesthesia and in sub anesthetic conditions for analgesia. Okay, nitrous oxide is used for maintenance of the anesthesia and sub anesthetic concentration for the analgesia. Then we will see the propofol. Then thiopental sodium. Okay, so these are remained. This all we will see in the next lecture.